Okay, I think we will begin. Welcome everyone to the Indian Academy of Neurology Young Neurology Forum. This is a very exciting case discussion series where we discuss two cases with clinical inputs from subject experts. And essentially, the cases take us through a journey of how the diagnosis, management, and evaluation is achieved in complex clinical scenarios. So I'm very happy to have two wonderful cases today, and let us begin right away with Dr. Ritwik, who I will welcome from Sri Ramachandra Medical College, Chennai, to introduce the presenter and initiate the case discussion. Dr. Ritwik, you're muted.
Yeah. Thank you, Dr. Divyani. So, good morning to one and all. It's a privilege to be part of this forum, and I thank Dr. Divyani and team and my head of department, Dr. Lakshmi Narasimhan sir, for this opportunity. We've tried to structure the case to reflect how it unfolded for us and highlighting information in the same sequence. The case will be presented by Dr. Saranya, our second-year resident. Over to you, Saranya.
Yes, sir. I'll be sharing my slides, sir.
Yeah.
While we're waiting for Dr. Saranya to initiate, I would encourage the audience to kindly type in your comments, queries, etc. into the chat box. And I'm also very happy to welcome Professor Suman Kushwaha, Professor of Neurology from EBAS, New Delhi, who will be the senior moderator for this session today.
Thank you, Devyani.
Looking forward to your inputs, ma'am.
Yeah, sure.
Yeah, please begin, Dr. Saranya.
Yeah, Dr. Saranya, you can start.
Yeah. Good morning, everyone, to all the respected faculties and panel members. Today, I'm going to share one interesting case, riddle of rhythm within Rumble. So, a 65-year-old male patient presented with 2 episodes of generalized tonic-clonic seizures. The patient had woken up and carried out his routine activities when, in the afternoon, the attendants had heard a cry from his room. Then they have witnessed bilateral tonic-clonic movements of all four limbs with associated uprolling of eyes and tongue bite. He was rushed to the hospital where he was loaded with levetiracetam. There was no prior history of fever, recent travel, sleep deprivation, or any change in his routines. Previous history, at the age of 62 years, a patient had an episode of encephalopathy for which he was admitted with sudden onset altered sensorium. At that time, MRI, brain, CSF, and other immune infection related investigations were normal. Patient recovered following treatment for presumed viral encephalitis. Since that encephalopathy episode, the patient had consistently experienced sleeping difficulties occurring nearly every night, characterized by difficulty in initiating and maintaining sleep with multiple arousals. There were no sleep related movement disorders, snoring, or daytime symptoms. For these symptoms, various medications, including benzodiazepines and at one point antidepressants, were also given for a short duration. Yet his insomnia persisted. And now at 65 years, patient presented with 2 episodes of seizures. Coming to the past and personal history, he was known diabetic and he was born out of a non-consanguineous marriage. Brother had similar sleeping issues. There were no neurological cardiac complaints in his family. Since the last few years, patient had experienced persistent bowel disturbances in the form of constipation, bloating sensation, and occasionally nausea, with mild transaminitis noted in recent reports, which was stable. On further examination, in the present episode, after post-ictal recovery, patient was drowsy but maintained arousal on stimulus. He was well-oriented and obeyed all commands. His attention was normal and registration recall was normal, and MoCA score was around 26/30, and his vitals were stable. On cranial nerve examination, visual acuity was normal, bilateral fundus examination was normal, bilateral partial ptosis was noted, and patient also had bilateral complete ophthalmoplegia, which was non-maneuverable. Bilateral pupils was normal in size. So here on further examination, we have noticed this kind of movement disorder, which was near continuous, semi-rhythmic, partially synchronous ocular involving both eyelids and the eyeball, and jaw and perioral movements which were absent in sleep and was not accompanied by any other involuntary movements. At this time, patient was conscious and oriented, and this video was taken when patient was asked to look straight ahead. And on other examination, motor, sensory, cerebellum, extrapyramidal, and other autonomic examination was normal. So, to summarize, a 65-year-old male with 3-year history of insomnia presented with unknown onset generalized tonic-clonic seizures and involuntary rhythmic oculofacial movements with examination revealing bilateral ptosis and complete ophthalmoplegia without motor, sensory, cognitive, cerebellar, and extrapyramidal involvement in the background of gastrointestinal disturbances.
Yeah, proceed with where and what is the lesion, sir?
So coming to where is the lesion? Well, with regards to insomnia, first symptom, it is mostly possibly localized to the orexin pathway, anywhere from the hypothalamus, thalamus, and to the brainstem connections. And the second symptom being the seizure, we were not able to localize or lateralize in the cortex at present. And the third symptom being the oculofacial rhythmic movements. At this point, we considered seizure, movement disorder, and a functional component. But the points against the seizure were that the movements were persistent and it was absent during sleep. And these movements did not progress and did not involve any other parts. And there is no consciousness impairment at this during the movement time. And the functional component was also shortly entertained, but considering the insomnia and the GI symptoms part of the psychiatric spectrum, but then it was more likely to be a movement disorder at this point. Then the examination finding of bilateral ptosis and the complete non-maneuverable ophthalmoplegia make it more likely to be an element type. But then we considered brainstem was also a possibility because of the involvement of multiple cranial nerves, but the absence of long track signs and the pupillary sparing was also there. And the non-fatigable nature and the bilateral symmetricity made muzzle also a possibility. And the movement disorder was possibly localized to the brainstem and its basal ganglia and connections.
Yeah, Dr. Saranya, I'd just like to pause you there for, I think the video was very interesting and I would love to have comments from the other panelists and Suman ma'am also. Can you show the video once again?
Yeah, I want to see the video again. So it's basically perioral movements, kind of rhythmic movements.
Yes, ma'am. Actually, the movements were in three segments. One was involving the eyelid,
Yeah.
where the retraction and contraction, and the eyeball actually in person, and which is subtly seen here, subtly protruded and retracted inside, madam. And there was a subtle downward movement in the eyeball as well. And the perioral movements were there along with jaw movements. So these were the areas which we felt.
Did you see the tongue and the larynx, the other parts?
Yes, no movement in the palate or anywhere else. So we checked all those places.
Okay.
And, this was semi-rhythmic, and it is the eye and the jaw and perioral were not exactly synchronous, but they're partially synchronous. One came after the other. And
it was very intrigued because the eye movements particularly is looking like a protrusion retraction.
yes, ma'am.
Yeah.
Like convergence retraction almost, which we see sometimes with the midbrain lesions. But usually when we think about oculomasticatory myorrhythmia, we have the convergence abduction adduction. So this was very unusual, I
A
think.
little deviant from the classically described version, yes, ma'am. So which is why we are not labeling it oculomasticatory myorrhythmia at this point. We just wanted to say it's a rhythmic ocular and masticatory movement.
What happens when you release the eye?
So
Is there any extra movement in the masticatory muscles?
no, actually we lifted the eye because we wanted to show that the eyeball is protruding. Because otherwise he had a subtle ptosis there. So we wanted to expose the eyeball.
One more way of doing it is to take a video from the side to look at the eyeball.
Yes, ma'am.
Yeah.
Can you just elaborate what was the sleep disturbance?
Yes, ma'am. Dr. Saranya?
Yes, sir. So he was not able to initiate sleep, ma'am, properly, and even if he initiates, it was not able to. He was not able to maintain sleep, and there were multiple arousals during the night. And during in a week, he was not able to sleep for like 3 to 4 days, and one day he was getting sleep. So it was that kind of um, that, like
So
symptoms.
the latency was prolonged, ma'am. And
Okay.
then even after the onset, there was multiple fragmentation, waking ups were there. And he seemed to go into sleep somewhere around 3 to 4, but this was not consistent. This would vary from night to night. So 3 or 4 nights he would have very unsatisfactory sleep, and following that one night probably a little bit better sleep, but then again the cycle would repeat. There are no daytime symptoms were there. He was fatigued, he was very drowsy, but he did not have any sleep movements or snoring or any other.
Okay.
Even if he tried to go to sleep earlier, or if he went to sleep little later, this pattern would still present. So it is not a circadian rhythm disturbance.
And what about GI symptoms? That's only constipation?
Yes, ma'am. So they were very non-specific. He said he had constipation and bloating. He ignored it for a while, and then he met the gastroenterologist who prescribed, tried treating him for that, but it persisted despite that. And he was noted recently to have some transaminitis, OTP2
Okay.
elevated, but it was not diagnosed. It was just left idiopathic, and yes.
Okay.
We'll move from the video, ma'am.
Yeah.
Yeah, thank you. Proceed, Saranya, with what is the lesion?
So coming to the what is the lesion, considering Occam's razor versus Hickham's dictum, a 65-year-old male presenting with a constellation of all these symptoms since 4 to 5 years, immune mediated was considered a possibility, considering the presence of seizures, movement disorder, and sleep and ophthalmoplegia. But the points against were the symptoms were too long to drawn out, and symptoms were very too temporarily dissociated, and there was no steady progression of the symptoms. Uh, and infection also was a strong possibility, considering the almost characteristic movement disorder, like in Whipple's. And but again, there was no steady progression of the symptoms, and it was too long drawn out, and the ptosis is less likely in Whipple's. Then the next possibility considered was endocrine or nutritional, like hypothyroidism, parathyroid, and thiamine deficiencies, but it did not completely explain the other symptoms like movement disorder. And the next possibility considered was drugs or toxins because of the history of exposure to drugs for a shorter time. But it was very long back and it was very short duration. But it did not explain the other symptoms like ptosis and ophthalmoplegia. And the last considered was genetic condition, mitochondrial was considered, considering the multiple systems involved here. But again, the age of onset was too old to label it as genetic. Coming to the course in hospital, the initial laboratory assessments revealed unremarkable routine blood work, and aside from mildly elevated liver enzymes, the endocrine and metabolic parameters were normal. CSF analysis showed normal protein, cells, and sugars. MRI of the brain was normal, and EEG was normal. Following initial stabilization, after 2 to 3 days, the patient's sensorium deteriorated to being drowsy with minimal verbalization. And the repeat MRI was done, which showed gyriform restriction in the right parasagittal frontal lobe with corresponding T2 flare hyperintensities. And the further evaluation for infection and immune workup was done for BioFire and HSV1-2 PCR, gene expert for TB, gram stain culture, fungal cultures, autoimmune encephalitis panel, paraneoplastic panels, VDRL, and Iglon-5, and which was normal. And repeat EEG was also normal. Diurnal biopsy was planned at this point. So narrowing down the differentials, First differential was infection, query Whipple's disease. The rhythmic ocular and masticatory movements, along with the chronic gastrointestinal symptoms, made Whipple's disease a possibility. But the long duration of symptoms and other ocular signs and the gyriform lesions in the brain made it less likely. Second was immune mediated. The patient's course was too protracted to conventionally fit into this immune mediated paradigm, but there was no contrast enhancement, and CSF was initially normal, and the autoantibodies were negative. And third was considered to be genetic, considering the patient's ptosis, ophthalmoplegia, and a very subtle family history, and the possibility that the MRI lesion was a stroke like lesion. Mitochondrial disease was also considered, but the apparent age of onset was too old.
Okay,
Course in the hospital.
Saranya, just 1 minute. I would like to have comments on the differentials from Suman ma'am, and I see Dr. Murthy
Yeah.
also here.
And do we want to connect the episode which has happened at 62 at the age of 62? That was when he has encephalopathy and everything was normal. And he was also normal after that, and again at the age of 65. So, do you want to have a continuum of the same disease, or you want to have a separate entities, both the? Because in elderly at the age of 62 he has had encephalopathy, and again at the age of 65 possibly there is an encephalopathy. So is something happening in between from 62 to 65 years of age?
Yes, ma'am. So we looked at it from
Yeah,
multiple angles. There is no residual, if at all there was a lesion at that time, there was no residual changes at this point when we did the imaging. Secondly, yes, that encephalopathy, presumed viral, could have triggered an autoimmune cascade and
yeah.
probably triggered an immune-mediated disturbance subsequently. So, and even if you consider this as in a genetic mitochondrial perspective, it could stretch out this way in a multiple years. So we did consider it part of the presenting only, ma'am, not separately.
And did you repeat his MoCA also? There is some possibility of any cognitive decline, because once the MoCA is reported to be 26, that is normal. But did you subsequently repeat
Yes,
it?
ma'am. So what subsequently happened was once he deteriorated, he started his sensorium dropped, and then he started having infection spiked up. So that we described him subsequently. So he wasn't back to his state until the very discharge. At discharge, it was 26 again.
Okay,
Discharge or at least at follow-up.
okay, okay. So still, I would like to keep a possibility of immune-mediated encephalopathy, although we are not able to pinpoint any antibodies in this particular.
Yes, ma'am. Yes.
Yeah.
Murthy sir, we would be very interested in hearing from you as well, if you're able to.
You are asking me?
Yes, sir. So what are
So
your thoughts?
basically, it looks multi-axial disease. There is a encephalon involvement, probably that generalized tonic may be focal onset to bilateral tonic clonic. And we not found any two repeat scans didn't show any white matter disease, except that gray viral enhancement, viral hyperintensity. This movement disorder doesn't look like typical of people's. I consider the possibility of a mitochondrial disease. So because predominantly it is a gray matter. So and multi-axial, and then you have MoCA is 26. I feel personally most likely it is a mitochondrial disorder.
Thank you, sir. Yeah, Saranya, you can please continue with your presentation.
Course in the hospital. So genetic testing was sent, and parallelly he was treated with pulse steroids, antibiotics, antivirals, and anti-epileptics, and mitochondrial supplements and L-arginine. The patient's intensive care unit course was protracted, marked by complications such as aspiration, sepsis, and 2 episodes of left focal myoclonic seizures, and new onset cardiac ischemia. He was discharged after an approximately 40-day hospital stay. And the genetic analysis whole exome with mitochondrial genome testing was done, which revealed a homozygous missense mutation, likely pathogenic, in exon 10 of the POLG gene, suggestive of mitochondrial disease. On follow-up examination at 6 months, showed that the patient was self-ambulant, able to carry out his daily activities with no focal deficits or any rhythmic oculofacial movements. His insomnia improved with lemborexant 5 mg with faster onset and sustained sleep maintenance. The attenders were counseled regarding the possibility of recurrent stroke-like episode, possible triggers, and the importance of preventing infections by periodical vaccination and hygiene. Unfortunately, the patient passed away a few months later after developing a viral pneumonia followed by status epilepticus.
Yes, thank you, Dr. Saranya.
So it seems very interesting actually. At the age of 63, somebody is having this mutation, but showing the manifestation of this mutation.
Yes, ma'am. So
Yeah.
when I met this gentleman and saw this movement, I really thought the time had come for the elusive Whipple's diagnosis, but it turned out to be something different and even better. And now this is for the residents. We have some strong learning points from this case. First thing in history, don't neglect the personal history. It might seem too simple, but information from that section can really help fill the gaps in your history and make the picture a little bit more congruent. I think the patient may choose to play down these symptoms very much as they might become accustomed to a certain way of life with regards to their sleep and bowel habits. But this gentleman actually played down his ptosis itself, which was noticed by a general physician around 2-3 years back, attributing it to his lack of sleep actually. And investigatively, I think identifying a stroke-like lesion is tricky, but definitely considering it in your differentials is important in the right setting. We have discussed regarding this in the discussion. And third point is that considering a possibility of an unidentified mitochondrial disease, as just ma'am pointed out in adults, it is a bit awkward explaining with conviction why we needed to do a genetic analysis in this age group to our intensivist. We saw their faces change from confusion to genuine concern for us. But in the right setting, I think it can help avoid worsening the situation in like choosing the anti-epileptics and so. Any further questions or comments? We'll be happy to answer.
I just wanted to ask this oculomasticatory movement or this ocular jaw movement.
Yes.
Usually, what is the localization for this particular movement?
So it goes to the brainstem, dorsal midbrain, and its basal ganglia connection. That's what when we looked at the literature, it was given.
Yeah.
So it also involves part of the red nucleus, which contributes to its synchronicity and so on.
Yeah, he didn't have a palatal tremor, however.
No, we checked that.
So the lesions in the MRI has actually made you think of mitochondrial, right?
Yes. Actually, putting everything together along with the lesion, we were prepared.
Probably the location of midbrain.
Yeah.
Yes, sir. So someone has asked if it could be CJD. I mean, when we looked at the gyriform lesion, yes, that thought shortly crossed our minds, but it was definitely not taken further, considering everything, the other history, clinical features, and everything put together, investigations put together. Yes,
Was
sir.
lactate elevated?
Yeah, we did do a routine lactate in the initial CSF. It was just borderline elevated, but that didn't make us think of mitochondrial at any point. So we did repeat in a CSF, which was again not conclusive. Lactates were borderline elevated.
I think the other clue was probably the liver dysfunction.
Yes, ma'am. So
yeah,
this is why I stress on the personal history that was a little subtle. They didn't even offer it much. So when we put things together, which I think I'll show in the next slide. Saranya, can you put the next slide? So when we rearrange the history, this is how it was actually happening, starting with the GI disturbance, which subtly was there, and then ophthalmoplegia, probably at 60. Then he had probably that was the first stroke-like lesion which he had. Then sleep disturbances persisted, following which he presented this time. He's not met a specialist anytime in this. So this movement actually triggered neurology call forth. So which is why we label this whole presentation rhythm and rumble in a crumbling brain. rhythm triggered the neurology reference.
So the history was very important in
Yes.
the past, the
Yes.
GI disturbances and everything.
Definitely, ma'am. We'll move on to the discussion.
Yeah. I think there's one more question. Duodenal biopsy.
It
What
was
did it mean?
actually it was planned, ma'am, but we didn't have many things going towards Whipple. As sir said, the movement was not very characteristic, and it was very temporarily dissociated. There was no progression. Whipples can be present for 6 years, but only the prodromal symptoms, I think, can persist for so long. Once the neuro Whipple starts, I think it is a little bit progressive, and ptosis was uncharacteristic. So we did entertain Whipples initially, but it was not our first or even second diagnosis differential.
Yeah. Thank you. Can continue, I think.
Yeah, Dr. Saranya?
Coming to the discussion, so the mutations in genes encoding the POLG, accounting for approximately 10% of all the mitochondrial disorders. Over 150 pathogenic POLG mutations have been identified. So the mutation observed in our case has been previously documented with a likely pathogenic association in a woman in her 50s who exhibited similar symptoms of progressive external ophthalmoplegia, ptosis, and gastrointestinal dysmotility, but did not manifest the other symptoms. So here is the criteria for identifying a stroke-like episode. For a probable stroke-like episode, the criteria is that acute or subacute onset of neurological symptoms and/or nausea, vomiting in a patient less than 60 years, and the presence of more than one of the following clinical criteria: BMI less than 20, history of sensory neural hearing loss, headache, and/or seizures at presentation, and an acute cortical lesion in a typical distribution for stroke-like episode. One is temporal involving at least the periopercular area, and occipital involving at least the medial occipital lobe, and any cortical lesion that does not follow a vascular territory. And the presence of more than one of the following neuroimaging criteria like cerebellar atrophy, presence of chronic cortical lesions with typical stroke-like episode distribution, hyperemia, and venous engorgement in the area of acute lesion on CT angio, and the evidence of no large vessel occlusion. And the criteria for possible stroke-like episode is acute or subacute onset of neurological symptoms, along with nausea, vomiting in the age less than 60 years, and the presence of more than one of the following criteria of BMI less than 20, history of hearing loss and seizures, and an acute cortical lesion as explained like temporal lobe, occipital lobe, and any cortical lesion that does not usually follow a vascular territory, and the evidence of no large vessel occlusion. So the takeaway points here is the stroke-like episode usually do not conform to a vascular territory and may appear gyriform. They progress by increasing in size to regress after reaching a nadir with no or residual structural brain damage. And MR spectroscopy of the lesion in the ventricles may show lactate peak and reduced N-acetyl aspartate peak, and there might be subtle differences between the hemispheres. And this is the spatiotemporal evolution of the stroke-like episode. So there are two patterns here. One is the anterior pattern, one second is the posterior. So in the anterior, it's usually the involvement of the medial occipital lobe first, further spread it to the occipital pole and to the lateral occipital cortex, and eventually extension to the parietal lobe. And the posterior pattern involves initial site of involvement will be the latero-inferior temporal lobe or the temporal operculum, further expansion to the frontal operculum and to the rest of the frontal lobe. So for the oculomasticated myelodemia, it's a form of disjunctive acquired pendular nystagmus, which was characterized by pendular convergence and divergence oscillations. In some textbooks, it was given as a protracted and retracted type of movements also, which is about 1 Hertz frequency and was associated with synchronous oscillatory movements of the jaw, face, or limbs. These are the sleep disorders which are commonly seen in mitochondrial disorders like excessive daytime sleepiness, insomnia, sleep disordered breathing, REM sleep behavior disorders, and circadian rhythm disorders.
Yes. Thank you, Dr. Saranya. So we've had a similar experience with another gentleman who we diagnosed with coenzyme Q10 deficiency at the age of around 60. we wanted to highlight a few points regards to the treatment. So the role of steroids, we think it might be useful because behind the pathomechanism of the stroke-like episode, there is significant vasogenic edema. So we used it in both cases, and it helped to us to an extent. And text states the role of L-arginine, which is controversial. It is a precursor of nitric oxide, and nitric oxide is involved, is exhausted when a stroke-like episode happens, and following a cascade of events. So we couldn't find an intravenous arginine, but we did try oral arginine in aborting the episode and preventing it as well, but we were unsuccessful. Thirdly, I think the choice of AEDs and the anesthetic agents have to be done very carefully, especially in the setting of a concurrent myoclonic movement, which is quite common in these conditions. Next slide, Saranya. So there are mitochondrial safe AEDs which have been described, but amongst these, some of them can trigger myoclonus, like you have gabapentin, lacosamide to an extent, oxcarbazepine, and so on. So we chose levetiracetam, zonisamide, perampanel helped, and yeah, with lacosamide also we had to risk. And second thing is utilizing the anesthetic agents when there is a status can be tricky because all of them have a direct effect at different parts of the electron transport chain, as you can see. So midazolam, fentanyl, both were reasonably not contraindicated, and we had to also risk ketamine at one point for this patient, not the presented patient. So I think those were the summative learning points we had to show. Thank you.
Can I add one point?
Yes, sir.
Yes, sir.
Acha, this posterior in mitochondrial the stroke-like syndrome, it is posterior cortex is the common.
Yes, sir.
That is one thing. And then coming to the anti-seizure medication, previously Jonasamide used to be the thing. Now perampanel is a better drug. But
Yes, sir.
subjected if the patient has any neuropsychiatric disturbances, then don't start perampanel because it can aggravate. But Jonasamide is a fairly safe drug.
Sure, sir.
Okay, that was fantastic learning points from both Dr. Ritvik and Dr. Saranya, and I think a lot of learning for the residents. There are a couple of comments from the audience. So, what mitochondrial cocktail treatment is recommended?
I'm not sure if it's recommended, but we went with coenzyme Q10, L-carnitin, nicotinamide, and pyridoxine. There was a drug with those combinations. So all these things were available per se, so we tried them. Literature also supported their use to an extent, but they were not game changers, just supportive.
You mentioned that you had used steroids in these patients.
Yes, madam. Pulse steroids.
Pulse steroids.
During the stroke-like episode.
Yeah. Okay.
It did help.
Yes, ma'am. I think it has definitely helped because once the seizures, in the second patient which I just showed, seizures did not stop until we started the pulse steroid.
Okay.
So,
okay. And there's one more comment. Actually, there are several more. Someone is asking what movement disorders are associated with Paul G in general and mitochondrial diseases that can present with stroke-like episodes and basal ganglia infarcts in mitochondrial disease. Okay, any comments on this?
the last question, I think infarcts, yes, I'm not sure. It can happen changes, but it was not there in this case at any rate. And I think MELAS, and actually I didn't realize Paul G could present with the stroke-like lesion at all until we had this case. And we've had two cases which are not MELAS which presented with the stroke-like episode. One was coenzyme Q10 deficiency and one was Paul G. So I think around these three diseases can cause stroke-like lesions. But I bet other mitochondrial disorders can also present the same way. And I think there's one more question.
Yeah, how do steroids presumably work?
Yes, so the pathomechanism behind the stroke-like episode, and at the end of the cascade, the lesion is technically predominated by a vasogenic edema. So it was when we started, it was empirical. So we just tried it because literature supported the role of vasogenic edema in the mechanism, so it worked. So this is the basic behind.
Steroids have been used in literature otherwise for.
Yes, they were described in case reports. There is no specific recommendation. There was one 2016 JAMA article which spoke about this and we took our point from there.
Okay, thank you.
So
And
I have one question. How common are the movement disorders in mitochondrial disorders?
Yeah,
My-
someone has asked that in the chat box.
what movement disorders are commonly associated with Paul G disorders? I think every movement disorder can be associated with Paul G when we looked at the literature, which is why we were confident that this unique movement could also be produced by Paul G. Anywhere from ataxia, your tremors, myoclonus, and everything, I guess, can be caused by Paul G. It is what we took out from the literature.
It is not the movement disorder, but epilepsia partialis continua is one of the features.
Yeah.
Later stage of the disease.
Yes, sir. Yes, sir. We did consider that as well in this case. Thank you. Thank you for your question, sir.
I think there are no further comments and questions from the panelists, and maybe Dr. Ritvik, you can address them in the chat box because we will move on to the second case. Thank you very much for your presentation, Dr. Saranya. Very well done, and Dr. Ritvik. It was a fantastic learning experience, and also to Dr. Suman and Dr. Murthy for their comments. With that, I will hand over to Dr. Ajay for the next set of proceedings.
Yeah, thank you, Dr. Divyani, and thank you, Dr. Sharanya and Ritvik. That was an excellent case. So we move on to the second case for today. They say lightning never strikes twice, but looks like in PGIM Chandigarh, it has struck twice. So the title of their talk is Struck by Lightning Twice, an Encephalopathy Enigma. And Dr. Siddharth Chand, who is a senior resident of neurology at PGIM Chandigarh, will be presenting the case and will be moderated by Dr. Abir Goel, who is an assistant professor of neurology, PGIM Chandigarh. Welcome you both, and I request you to carry on with the case now.
Thank you, sir, and good morning, everyone. And first of all, I would like to extend my thanks to the previous team for presenting a very wonderful case about a mitochondrial disorder. And I hope to extend the same discussion in our case also. Though our case it focuses less on the localization, but on a very important aspect in a neurology, that is the neurological emergency. So for the residents, this is one thing which we see every now and then, a neurological emergency, which every resident is gonna come across every day in their emergency. So we're gonna see how we are approaching that case, and is there a twist in that? So not wasting time ahead, I pass on to Dr. Siddharth to present the case.
Good morning, everyone. I am Siddharth. I'm a senior resident in the Department of Neurology. So today I shall be presenting an interesting case of encephalopathy. So our index case was a 23-year-old lady. So this was in the autumn months in the late monsoon phase. She presented to us with complaints of fever, which was high grade. About 2 days later, she developed dizziness and confusion. And after that, she had rapid deterioration in her sensorium. This was not associated with any headache or any seizure or any other focal deficits. Since she had such a rapid deterioration in her sensorium, initially she was evaluated in a local hospital where she was diagnosed as dengue because of her NS1 positivity. And subsequently, she was referred to us. When I saw this patient in the emergency, her GCS was E1-VT-M2. Her cardiovascular vitals were stable. She had decerebration and she did not have any meningeal signs. The pupils were small, but they were anisocoria and they were not reactive to lights. She had grade 1 papilledema and the other brainstem reflexes were absent. The other systemic evaluation was normal. So at this time, I was evaluating her as a case of something as of a febrile rhomban encephalitis with a possible localization at the level of midbrain. So the different diagnoses which came to my mind, because it was the month of late October, in a North India, the patient might be suffering from any typical infections such as dengue. Her NS1 was positive, or the other atypical infections such as scrub, maybe other viral or bacterial etiology. The other possibilities were some metabolic encephalopathy or some para-infectious demyelination. She already had got her MRI done from the referring hospital. Here, I would like to point out that she had bilateral symmetrical T2 flare hyperintensity in the basal ganglia, predominantly in the lentiform nucleus, in the external capsule, some in the thalamus also, and she also had lesions in the brainstem. Since she had such a rapid worsening in her sensorium, we got the MRI repeated at our center, and we saw that the lesions had actually progressed within 2 days. She had bilateral symmetrical hyperintensities in the thalamus, in the external capsule claustrum, in the brainstem, pons, and brainstem also. And interestingly, she had diffusion restriction with ADC reversal with bilamellar appearance. The SWI showed blooming. So our approach to this patient became that she is probably having something of an hemorrhagic encephalomyelitis type of picture. So based on this MRI picture, the different diseases that we thought about was probably she was having dengue encephalitis. And I'd like to remind that her NS1 was already positive. So this was a study which was published from our center only. The different MRI picture in a case of dengue A&E can be that there are bilateral symmetrical hyperintensity in the thalamus. There are a diffusion restriction along with blooming seen in the SWI. The second pattern which we could have think about is AHEM, which is a poorer prognosis of ADEM. The other was less likely, but we also kept a possibility of adult onset Lee disease, which also has similar bilateral symmetrical hyperintensity in the basal ganglia and the brainstem. The other possibility, just like we discussed in the previous case, probably some rare form of mitochondrial cytopathy or mitochondrial encephalopathy, or just rarely biotin responsive basal ganglia disease. We got her routine workup done. Her platelet counts were normal. CRP and ESR were mildly elevated. We got the CSF done, which showed mild lymphocytic pleocytosis with definite increase in the protein level. The CSF pan-viral that we sent in our center was negative, and the other infective workup in the CSF was also negative. In our center, the dengue IgM was positive, and the other workup which was done was negative, including the like HIV, HBsAg, anti-HCV, NMO, MOG, and the other investigations were all normal. Now, at this time, we actually got some interesting.
So yeah, so before we go ahead with the family history, so yes, for all the residents, what I would want to say is that this was the case when she had presented to us with a febrile rhomboencephalitis in the form of that, yes, she had a decerebrate rigidity further localizing to a lesion in the brainstem below the red nucleus, also in the form of an isochoria with myotic pupils, poorly reactive to light, also taking us to the brainstem. So our lesion was more of a febrile rhomboencephalitis. So definitely, whenever a patient like this comes to us, even before the MRI, we think about the infective cause for rhomboencephalitis. So we did send for all the infective workup for rhomboencephalitis, which came out to be negative for us. Now, again, looking at the MRIs, MRI show a fluffy shadows, very much hyperintensities in bilateral thalamus, symmetrical hyperintensity in bilateral thalamus, brainstem, external capsule. So we were a bit puzzled that are we dealing with some mitochondrial disorder which is triggered after the infection, or are we dealing still with the rhomboencephalitis which is still not come in a CSF workup? So while we were treating the patient, very surprisingly, just as a when we were taking the history, we got this family history which Dr. Siddharth is going to show.
Just before that, can we go back to your DDs after the radiological discussion? So probably you could tell us more about why you considered biotin responsive basal ganglia disease.
Actually, it was just to complete the list of diseases that we do, because she had these fluffy bilateral symmetrical hyperintensity in the basal ganglia lesion in the thalamus, and so it was just to complete the lesion.
And in a center on the pediatric side, we have seen some biotin responsive basal ganglia diseases, which we probably did not think of before looking at those cases. So this was more as our attempt to look at something which is probably corrective for the patient and which is treatable for the patient. So yes, that was definitely down the line. That was not in our top 4 or even early in our differentials. So, but just for a treatable cause, we had kept that.
But you didn't find any other pathognomonic signs like the donut
No.
sign. I can't see anything in the cerebellum like that, but you
No,
didn't find anything
no.
like that, right?
So Siddharth, can you just take to the radiology? Previous slide.
Yeah.
Previous
So
slide.
so
Yeah.
this was in the outside center.
Mhm.
And this we got done on the day 5 of her illness, which was
So what you
about
can see here, the lesion is involving bilateral thalamus. The lesion is involving the external capsule. The lesion is involving, even if you see properly, the lesion is involving the brainstem as well as the medial temporal lobe. So going to the next one. So if you see at the diffusion restriction, there's a very distinct pattern of diffusion restriction in those lesions. So if you see the thalamic lesions also, there are three different levels what you can see in the diffusion restriction. Right in the center, just in the center, you can see the ADC is not completely reversed. Siddharth, can you point out at the thalamus? Yeah. So if you look at the right thalamus, just focus on the right center, completely in the center. There is a mid hyper to iso intensity in the there, surrounded by a ADC reversal, complete ADC reversal, which you can see in complete black zone, and surrounded by another concentric zone of hypointensity. So you can see there is three distributions of a diffusion restriction in one lesion, which we call as a trilaminar. Hello, Siddharth.
Yeah. So basically,
Your
she
thing is not
he
visible.
hi, am I audible? Are the images visible?
Yeah. So
Can
as we
I
can see,
can I make a comment?
yes, sir.
This type of picture can occur in RNA encephalitis. RNA group of virus.
And sir, and that is
Like
why
dengue fever, Japanese encephalitis.
that is why we had sent for a CSF pan-viral, sir, thinking that we are actually dealing with a enteroviruses or a Japanese encephalitis or even a dengue encephalitis since the patient had a dengue. But this diffusion restriction in the form of this trilaminar distribution was a bit odd for us, which we had not seen in dengue encephalitis before. And again, Siddharth, your video is not visible.
It's not visible.
Maybe
Is my video visible?
you can stop
No.
sharing and reshare.
Are my
Yeah,
slides visible?
yeah, they're visible now. So considering this very characteristic pattern of this diffusion restriction, so we had thought that probably this may be some rare different presentation of a dengue encephalitis or some Robin encephalitis due to some enteroviruses or some, as a rightly said, some RNA viruses. Also, what you can see is that the involvement of the external capsule in the claustrum region, they are not very commonly involved in these RNA viruses as well as the dengue viruses. So yes, we had a bit of oddities, but patient did have a dengue NS1 positivity. Patient did have an IgM dengue positive. So were we dealing with a slightly off presentation of dengue encephalitis, or were we dealing with something else? So that was a conundrum. Patient was definitely in an M1, M2 status, not in a very good shape. So while looking at this patient, Dr. Siddharth managed to get one surprise for us.
I just wanted to ask about the trilaminar pattern that is usually seen in ANEC, right? ANEC?
Yes.
Yeah.
So, and that is why we had shown one dengue associated ANEC pattern.
Yeah. Yeah.
So, which was there in this thing. So, yes, one of the our differentials after after seeing the hemorrhage, after seeing the trilaminar pattern was annexing.
So now coming to the family history, it was very surprising for us. So 5 years ago, her father at the age of 40 years had a exactly similar history. So he had also developed high-grade fever and subsequently he had developed rapidly progressive encephalopathy. He was also evaluated at an outside center. We reviewed the records. He was dengue NS1 positive. There were no other any hematological or biochemical abnormality. Probably CSF was not done. We could not retrieve the CSF data. The family got the MRI picture to us, and surprisingly, her father had almost similar kind of MRI lesions. So here we can see that the NCCT head showed bilateral symmetrical hypodensity in the thalamic lesion. The T1 showed hyperintense in the thalamus, as well as some hyperintensity in the medial temporal lobe. He also had T2 flare, bilateral symmetrical hyperintensity in the thalamus, in the external capsule and the claustrum area. And we did not have the SWI images, but corresponding it to the T1 images, probably he also had this similar kind of an hemorrhagic uh, lesions in the bilateral basal ganglia, thalamus, as well as the brainstem. Now, we actually investigated further and we took a detailed family history. So, three of the father's siblings had actually died in the early childhood, and all three of them had some kind of an febrile illness. The family did not remember much, and there were no definite formal records for it. But this was the pedigree chart that we could analyze. So, no, after this family history, we could make out that probably this is some kind of an inherited disorder, maybe some kind of an autosomal dominant disorder. The MRI picture uh, was matching with the previously documented mitochondrial diseases. But the issue that was troubling us was that all the family members had definite history of fever in them. And with the index case as well as the father having documented dengue infection. So we were not sure what exactly are we dealing with. Is it some kind of an infection which is triggering an immune disease? Because if you remember, the CSF showed raised protein, it was 473. So we actually did all the workup for that. We did a muscle biopsy in the patient, which was normal. And after that, we actually sent for the whole exome and mitochondrial analysis. The mitochondrial genetic report was normal. However, the clinical exome actually showed a RAN-BP2 mutation. At this time, it was showing an uncertain significance, and the our index patient actually had a methionine to threonine mutation. We got a Sagner validation done. We asked for the genetic analysis of the father also, and surprisingly, he also had the similar genetic variation. So we revised our diagnosis to a familial acute necrotizing encephalitis due to RAN-BP2 mutation. Abhi sir, would you like to comment something?
Yeah. So yes, as ma'am rightly said, that we are dealing with acute necrotizing encephalitis, which was probably triggered by dengue, which we also call as a dengue acute necrotizing encephalitis or DANE. But yes, the familial involvement did tell us that there is some genetic workup which is predisposing these individuals to have a excessive response to this dengue virus, thus causing this necrotizing encephalitis. Now, why is it so important for us to know? Because to be very frank, when the patient had presented to us in the emergency, we did not know about this. We did not really know that there can be a familial necrotizing encephalitis. All we knew that, yes, one of the differentials was dengue encephalitis. Since we had seen a case of dengue acute necrotizing encephalitis, one of the differentials was a DANE. But the familial causes, once the father history and the other familial history came into the light, we were more swayed towards the mitochondrial, which came out to be negative. So, what is the real significance of this RAN-BP mutation? And second, if the mutation is present in all the family members, why some family members they had shown a symptom? If we consider those three deaths at the early age to be at the earlier age, and why some are showing at the age of 45, some are showing at the age of 20. So these were the certain questions which were really troubling us, that is there a complete penetrance of this mutation? Number two, what is the significance of this mutation? How can it really help us in our further clinical practice? That next time a patient comes to us in emergency, how can we utilize this information in this family or in any subsequent patients for to decide our treatment plan for that? Next.
Yeah, so this acute necrotizing encephalitis, which is ANE, is in itself is a very rare disorder. ANE per se is actually more common in the infants and the young children. And the typical history is that there is a high-grade fever followed by encephalopathy. So we have known about this entity called ANE since the past 20-25 years. So these are the documented cases which have been there in the literature. Predominantly, the cases are in the pediatric age group, and the viruses which are known to elicit this ANEs are influenza viruses, some other respiratory viruses. Dengue is rarely reported to cause ANE. So the diagnostic criteria for ANE is that it is a viral febrile disease and there is a rapid deterioration in the sensorium. There is usually there is no CSF pleocytosis, and there's definite increase in the CSF protein. And in the brain imaging, there is symmetrical multifocal brain lesions. And these are the other cases of, like, when we reviewed the literature, we found that subsequently this ANE which occurs in this familial has now been labeled as ANE1. And this is the mutation in this gene called RANBP2. It has been documented predominantly in the European families. So this ANE1 actually has a recurrent episode, and it is actually known to cause about recurrence in 50% of these cases. But here also this ANE1 occurs mostly in children, and the peak incidence is in the 6 to 18 months of age group. And also, but there's an incomplete penetrance. We still don't know why it affects some of the family members and why some family members are protected by it. Probably it has differential phenotypic presentation. This RANBP2, basically it is a nucleoporin protein. It has significant role in this nucleocytoplasmic transport. It is actually also involved in the mitochondrial function. But why is a viral infection eliciting such an hyperimmune cytokine storm? The reason for this, because of the mitochondrial dysfunction, there is an increased activation of the immune system, which leads to an increase in the IL-6 and TNF alpha, which leads to the MRI findings which we had. So the history that we found in the literature was it mostly affects the healthy children. There is rapid progressive encephalopathy, seizures, and coma, and it usually occurs within days of onset of a febrile infection. And there is usually no evidence of any direct viral penetration of that infection. So we still have some questions unanswered, like why it is triggered by infection, why same phenotype but different infectious agent, and why is it limited to some individuals? Probably there are some other host factors which lead to a differential phenotypic presentation. So these are the other pathogens which have been documented to cause ANE1. Here we can see that dengue is actually not reported to cause ANE1 till date, and I could not find any report from India which is causing dengue ANE1. But there are some difference between an isolated case of acute necrotizing encephalopathy and this genetic ANE, which is called ANE1. So there's a high recurrence rate, and this ANE1 usually involves only the central nervous system. So in the cases of isolated ANE, probably the patients also have thrombocytopenia, they have raised liver enzymes, and in the brain, the involvement is usually in the thalamus and maybe sometimes in the brainstem. But here in ANE1, it involves the medial temporal lobe, the external capsule, and the claustrum also. And this is very characteristic. Like if we ever get a patient who has an involvement of the external capsule as well as the claustrum, we should be suspecting genetic ANE more than an isolated ANE. So these are the other rare variants of ANE1 which have been documented, like transverse mellitus has also been documented with ANE1. So now how to differentiate from other causes? Now, as I said, like this type of presentation is very common in North India, like late monsoon in the month of September and October, many patients who come to us who have dengue and then they present with encephalopathy. Now, dengue encephalitis usually has the syndromic presentation, which is the characteristic ANE, or sometimes they have ADEM-like picture. Occasionally, they might have acute encephalitis with normal imaging as well. So the dengue encephalitis, which the traditionally that has been documented. Now, I would like to point out that this is a normal A&E. This is not A&E 1. So they have a bilateral symmetrical thalamic involvement with bilamellar or trilaminar appearance. Brainstem can also be involved. So this is a review of about 170 patients, which was recently published. They analyzed cases of dengue A&E along with the other cases of sporadic A&E and the genetic A&E, which is A&E 1. Here we can see that the sporadic A&E as well is more common in infants and children, whereas the genetic A&E, it can present in adults also. And this mesial, temporal, and external capsule involvement, as I mentioned previously, in sporadic A&E, it is rarely present. However, in a case of genetic A&E, it is usually present. And this is our clue for the diagnosis was in our case. Now, how do we differentiate it from other causes of ADEM? Now, the reason why we thought about ADEM was she had this fluffy and hyper intensities, and that was the reason why we sent for an NMO mock panel also. But the ADEM usually they present few days after fever. But in our index case, she developed altered sensorium on day 3 itself. Usually in cases of ADEM, the fever might have had resolved also. The CSF might show lymphocytic pleocytosis in cases of ADEM, and the brain lesions are usually less symmetric. Now, a few words about this Lee syndrome. Now, Lee syndrome is usually present in the children. However, adult onset Lee syndrome has also been described. But about this Lee syndrome, it usually has a subacute presentation. It has a progressive neurodegeneration, and it usually has these other findings also. They may have these movement disorders, and there are other systemic involvement like cardiomyopathy, hearing loss, or visual loss. And in the brain imaging, they have characteristic lactate peak in MRS. So now coming on to the treatment options for a case of A&E as well as A&E 1. What we did for our patient was actually at the time when we were treating her, we were not sure what exactly was the diagnosis, but we found that she was having raised CSF protein and there was a definite progression in her MRI imaging. So with the consent of her family, on day 4, we started her on IV methylprednisolone, and from day 5 we had started her on 2 gram per kg IVIG, which was given over 5 days. The patient was subsequently discharged from a center after almost 30 days. At the time of her discharge, her sensorium was actually E1 VT M2, but gradually she improved. So the treatment option, which has been documented in the literature, is that we can give corticosteroids. The reason for giving is that it has immunomodulatory effect. IVIG can be given, but then I would like to talk about this IL-6 inhibitor. This is tocilizumab. Now, many reports of A&E have showed that IL-6 is markedly elevated, both in the serum as well as in the CSF. And tocilizumab, if given within 24 hours, have a very good role. And some of the reports have actually reported complete recovery. So this is a case which was published from China. This was a case of A&E, which was caused by influenza A virus. On the day of presentation, this child had markedly elevated IL-6. They gave the child tocilizumab, and this was the IL-6 and TNF-alpha levels after 5 days of treatment. And this child apparently had a complete recovery. Sir, would you like to add something?
Yes. So our main purpose today is to discuss this case and probably spark a discussion amongst everyone, amongst all the residents, amongst all our peers, that whenever a case comes to us with a picture suggestive of acute necrotizing encephalitis, also involving the bilateral external capsule claustrum, do think about this ANE1 as an entity. Even though in our case, we had an overlap between a dengue acute necrotizing encephalitis and a ANE1, reason being that our case did have some CSF pleocytosis, reason being our case did have a dengue as a trigger. Also, reason being that patient did have a familial involvement. So yes, we did have an overlap, but the most important thing why to recognize these cases, so as we can see, there are recurrences known whenever we have this mutation. So now this girl, we know that now we have diagnosed this father, we have diagnosed the family members, we are screening them for the same mutation. Now they are prone for all of these acute necrotizing encephalitis, which as we can see here is a devastating problem. So our take home message from here, what we feel should be that whenever the patients with a known RAN-BP mutation, with a known familial RAN-BP mutations present to us in the emergency with a typical prodrome of a viral infection and very rapidly progressive neurological symptom, first day we can definitely go ahead with a CSF or a serum IL-6 levels, and irrespective of that, we can definitely start on a tocilizumab. Why? Because there are very few case reports, in fact, very few studies on ANE1. But whatever case reports, what we had reviewed, something which we could not do in our patient, probably which we will be able to do further down the lane, is that whenever a patient comes to us, send for a serum IL-6 and start a tocilizumab on the day one, probably we can have a better recovery of a patient's rather than our index patient. Though our index patient did recover for a bit, but as reported in the previous case reports, even if the patient have had a brainstem lesions, which generally is considered a bad biomarker or a bad prognostic marker, these cases after having tocilizumab have definitely shown an improvement. So yes, this case definitely opens a Pandora of when to consider an ANE1, what to do whenever we have an ANE1, and further we can definitely as a collective study on these cases and further come up with a solution to these.
Yeah, so a little bit about the severity score. Actually, this has been developed for in cases of A&E. So they actually reviewed about 73 to 80 cases of A&E, and they found that patients who actually have this thrombocytopenia and brainstem lesion actually have poorer prognosis down the lane. So this was the MRI of the father, which we got done at follow-up. We can see that he has marked cerebral atrophy as well as there's atrophy of the brainstem also. So this was the video which was sent by the family. Unfortunately, the father could not come to us for evaluation. This was a homemade video. So this is the MRI of our index case at about 5 months. Here we can see that she has a bit of atrophy and gliosis present in the thalamus and the brainstem area. And this was the evaluation which was done at 5 months. Left hand उठाओ. उठाओ. कहाँ रहते हो? पैर सीधा करो. अच्छा. पैर सीधा करो. पैर मोड़ लो. संडे से लेके सैटरडे तक. So summarizing my presentation, so this is actually a very rare entity. It is triggered by a febrile viral infection. It involves the males and females equally, but definitely it involves the infant age group more. The underlying risk factor is a heterozygous or a homozygous mutation of the RANBP2. There we still don't know what is the exact treatment that we should be giving, but probably aggressive treatment with IVIG steroids and tocilizumab should be our treatment options. And so the take-home message is that we should always think about any if there is a family history, if there is any recurrence, and MRI shows symmetric lesions affecting especially the external capsule, claustrum, or the mesial temporal lobe. So,
thank you. So yes, definitely, I would want to discuss on this case, which probably would want to know some feedback on what the experiences of at other institutes and how others have dealt with such cases.
Thank you, Dr. Abir. Excellent case. I think very pertinent points that you have made. I think though we see a lot of ANEs here in immense as well, but I don't think we have this particular NBP2 mutations that we have noted. Of course, I would also have thought of mitochondria like you had thought of. So this has opened up our eyes. But if anybody else has some experience with this, they can probably share that. Meanwhile, just one question. So are there any vaccinations or any such things which are recommended so that given that these patients are more susceptible to develop encephalopathy? So any advice on that regard that you should be careful with some?
Definitely, sir. But we per se, since this is a very new mutation, what we are reviewing all across the world, so we don't have any recommendations on that. And per se, I'm very scared of giving a live vaccine for such patients. I don't know how these patients would respond to that. So I'm still not sure of that. Okay, whether we should be giving any live vaccines to such patients, if those live vaccines will trigger any cytokine response, because definitely in such patients also it's not the first time they had got some viral infection. So they are showing a very different, a very heterogeneous response to any infections also. So vaccinations may help, may not help, may even trigger a response or immune response like we used to see in GBS. So I'm really not sure of that.
At this point, I would like to invite Dr. Suman for her comments.
Yeah, I would like to ask Dr. Abir that in the patients of presenting with acute encephalitis, so the very important point which you have made, if the patient is rapidly progressive, and so doing the interleukin 6 or other inflammatory marker will be a good idea in the patients who are rapidly progressive. Because I think in my personal experience, I have not done it yet, getting the interleukin 6 done in the patients for necrotizing, for other encephalitis, I mean to say. So how you want to recommend doing interleukin 6 in the patients of encephalitis? Because in North India, in post-monsoon period, we are expecting to get a lot of patients with encephalitis.
Definitely, ma'am. Probably on the day one when the patient presents with the acute encephalitis, we can get a serum interleukin, but with the pinch of salt, that we still don't know what is the cutoff for the interleukin 6, which will differentiate a necrotizing reaction, which will differentiate a normal encephalitis reaction, which will differentiate an MRA negative reaction. So probably that is something which we can study in future as to whether the IL-6, a different IL-6 response is correlating directly with the response also in the brain.
Yeah.
So based on that only we can decide whether we want to give an immunomodulation, because IL-6 being a immune mediator will definitely be raised in all kind of infective reactions. So whether a hyper IL-6 response will help us in deciding that, okay, this patient needs an immunomodulation along with antivirals or antibiotics, what we are giving, versus a patient which has a slight IL-6 buildup but may not need an immunomodulation.
Yeah,
So
because
that is the purpose of me trying to discuss that whether if we should start doing IL-6 in further patients.
yeah, this will be actually helping us in delineating the patients who will be requiring immunomodulation at that point of time.
Yes, ma'am.
And I think we will be needing experience for this. We should all start doing it in some set of group.
Yes, ma'am.
If I may ask a question, very nice presentation, Dr. Abir. Just wanted to know how comfortable would you be to give tocilizumab in the Indian scenario of a patient presenting with encephalitis, knowing well that it can lead to profound immunosuppression and further complications along the way. Because even if somebody has dengue-associated encephalitis, it may, there'll be a fear that it may further propagate the infection and trigger further downstream effects.
Definitely, Dr. Ayush. The conundrum between the infection and immunomodulation always stays, which we had seen in TB, which we are seeing now in crypto, which we probably saw in COVID also. That what is the tipping point when we should start considering immunomodulation is still not known, and that is why this role of IL-6 is what I was being considering. In our index case also, that is why we were very you can say not very confident, and we gave only IVIG being big safer in the this thing in the infection. So at present, if you ask me, I really won't be very comfortable unless I see in the MRI some necrotizing reactions which are suggestive of hyperimmune response, or if probably an IL-6 goes through the roof. Probably in those cases, tocilizumab. but I'm still not very sure of what is the correct time to give a tocilizumab.
Okay, thank you. Now we'll question some of the questions from the panel may be answered. So we have some questions here. Dr. Narendra is asking if there is any age predilection for ANAC. And Dr. Akash asked for a simplified approach for patients with ANAC.
So for an ANEC, yes, as we saw in the table, ANEC and ANEC1, they both are different. So ANEC is the sporadic ones, ANEC1 is the familial one. So ANEC generally affects the children or the young adolescents, but ANEC1 follows no age. As seen in our case also, and as seen in the literature also, the familial ANEC can affect at any age. Because of the different incomplete penetrance, some family members may be involved, some may be involved at different ages. So there are no age predilection for ANEC. Coming to, is there any role of mitochondrial cocktail to prevent recurrence? In such cases, no, because this is not per se a mitochondrial disorder. This is per se an hyperimmune disorder. Yes, we have definitely, since it's a nucleoporin protein, so we know that it has an effect on mitochondria. That's why the MRE picture may also mimic leaks, but there is no role of mitochondrial cocktail to such cases. What prompts you to assess a family history in ANAC, and do you recommend to subject for a whole genome sequence in suspected dengue encephalitis? No, not at all. Not at all in any dengue encephalitis. So a patient who presents to you with any febrile illness, any dengue, a patient has got a hemorrhagic lesions, a patient got a necrotizing lesions, specifically look for this bilaminar and trilaminar lesions. Now, the lesion which I showed in the thalamus, look for the 2 zones of diffusion restriction or the 3 zones of diffusion restriction. So if you're getting this bilaminar or trilaminar, especially with the involvement of external capsule, claustrum, and medial temporal lobe, specifically external capsule and claustrum, which are not really seen in other viruses commonly, do think about ANEC1, and then we can suspect a whole genome sequence in those patients. Any role of TNF alpha inhibitors? Since IL-6 is more predominantly raised than TNF alpha, definitely we can explore that. But after, I would first want to explore the role of IL-6. And we commonly see such MRA in clinical setup in dengue and Japanese encephalitis. Should we start standing? No. Again, let us not have this as a take-home message that every dengue and Japanese encephalitis, or as a matter of fact, any infective robin encephalitis, let's not start sending all the genetic tests in such individuals. The most important would be look for these specific areas of involvement. Again, I would want to reiterate in the involvement of external capsule, claustrum, medial temporal lobe, look for bilaminar, trilaminar distribution, look for necrosis, and then also ask for a history, a subtle history that any death in the family after a febrile illness, do send for genetic tests in such individuals. So that would be also an approach to acute necrotizing encephalitis. Always remember, these people come with 3 phases. Number 1 is a prodromal phase, which is a very short-lived phase, a very 2 to 3 days of phase in which the patient has got cough, any viral infection, cough, diarrhea, vomiting, followed by a very rapid progression of either a decreased sensorium, an altered sensorium, or recurrent seizures. So a patient comes to you with a very rapid neurological deterioration after a short history of a prodromal symptom with this pattern of involvement, this pattern of distinct involvement in MRI in the form of external capsule, claustrum, apart from bilateral thalamus, symmetrical lesions, bilaminar or trilaminar distribution. Please think about these cases. As we correctly said, start sending IL-6 levels in CSF and serum, and then we can probably have a decision as to when to start using immunomodulation in such cases.
Yeah, I think we still have 5 more minutes, so maybe a couple of more questions. One question is on the role of TNF alpha inhibitors.
Yes, sir. So again, TNF alpha inhibitors, whenever we see the immune response is predominantly of an IL-6. Definitely the second thing in that cycle is TNF alpha. So TNF alpha inhibitors may be useful, theoretically can be useful, but again, I would want to explore an IL-6 inhibitors before that.
Yeah, I think the last it's a comment by Dr. Isha, who says who agrees with you that abnormal interleukin-6 levels in CSF and serum should be used and done more rationally, and it might be quite useful. Right. So, any final thoughts or comments before we wrap up this session? Murthy sir, any comments from you, sir? Okay.
Extremely difficult to suspect anyone here in this patient. See, that type of picture can occur in dengue, MRI picture. And what is the platelet count in that patient?
It was normal, sir.
Huh?
The
Usually,
platelet counts were normal.
one of the dictum in some articles say any ADM picture with hemorrhage within the lesion or this type of mainly midline structure involvement with hemorrhage. Dengue is one of the important differential diagnosis. Very difficult to clinically to suspect any, but more so age of onset. Generally, we expect them younger age. So this is a lesson. Only here, what helped you to investigate further is the families. That's all. I will emphasize any encephalitis with family history, then go for any.
Yeah.
Absolutely. So thank you for your comments. I think they have rightly given their caption that the lightning doesn't strike twice, and that is something. If it has, then you should see what is the reason that might be that this has happened twice in the same family with some tragic consequences as well. But overall, I think very well presented and very well discussed, and you have brought out the points related to any in a very detailed manner. So profusely thank you. With that, we will wrap today's session. We will have the next YNF session on the 10th of August. So if you have any cases, any such cases that can be presented to the larger group, we would welcome you to send a letter of interest to us. With that, we will wrap up today's session. I thank you all the listeners who have joined in. I thank all the panel members for chipping in with their valuable comments. And special thanks to Dr. Siddharth, Dr. Sharanya, Dr. Abir, as well as Dr. Rutvik for bringing out this session and carrying on with the discussion in a very beautiful manner. I'm sure it was useful for all the residents and neurologists who have joined in. With that, I would like to thank IAN for helping us to bring out this session in a very regular manner. The digital team has been very helpful and has helped us carry this in a seamless way, and I'm deeply grateful to them. Special thanks to Dr. Divyani, who very efficiently manages the session from time to time. And she's extremely efficient with whatever she does and brings it out in a very perfect manner. So thank you all for joining in, and I hope to see you all again on the 10th of August. And we would be very glad if you could send in more cases and help us all learn along with you. Thank you. Thank you.
Thank you.
Thank you.